So these sessions were birthed out of a desire to bring more voices to the table in our policy and advocacy work through all of the changes and lessons learned in the last year. One of the biggest for us is that we haven't provided many opportunities for the agencies in the programs we fund to interact directly with the stakeholders in the rest of our work. Our volunteers and staff, particularly when it comes to developing our public policy agenda. One of the recommendations of our United Way Staff Diversity and Equity Committee was to host a series of meetings to better inform our stakeholders of the challenges in our community and to provide space for the agencies to speak for themselves. Today, we're going to hear from some of our impact partners who cover the health spectrum from maternal infant health, primary care, disabilities, mental health, and older adults. And we'll have a chance to go into small groups to discuss what we've heard and share out in the end in a larger group discussion some of the major challenges and potential solutions that we want to consider as a community. So first off, I'd like to ask our public policy committee members to come off mute, come on camera, introduce themselves, and then we'll get right into the program. Everyone else, if you could please introduce yourselves in the chat, please go ahead and do that. If we were here all in person, we would have time to do this all in a roundtable, but since we're on Zoom, it gets a little cumbersome. So public policy committee members, if you could go ahead and introduce yourselves.
Well, good morning. My name is Gabriel Parra. I'm the Executive Director for the ARC of South Florida. I'm part of the Public Policy Committee. I'm representing the agency executive directors.
Hi, good morning. I'm Matthew Pinzer. I'm a Vice President and the Chief Marketing Officer at Jackson Health System.
Good morning, Natalie Castellanos. I'm the Director of Policy and Public Affairs with the Health Foundation of South Florida.
There's a few more of you. Let's see, Priscilla, do you want to go ahead and introduce yourself?
Yes, hi, I'm Priscilla Greer, and I am a grant writer for the Salvation Army of Miami.
Oh, sorry, I was sorry, Priscilla Marrero. Could you go ahead and introduce yourself?
Oh, can you hear me? Hello? I'm Priscilla.
Priscilla Greer, we can hear you. I'm asking Priscilla Marrero to introduce herself.
Oh, I'm sorry.
Oh, hi, everyone. I'm Priscilla Marrero. I am partner of Creative on Demand Hispanic Advertising Agency, and I'm happy to be part of the policy committee.
All right. I think that is all of us. All right. So as I think many of us are very aware, our work is really focused on this group of people called ALICE. ALICE is families who are asset limited, income constrained, and employed. They are families that don't have the income needed to afford the most basic household budget in a community in the United States. There are households that earn too much to qualify under the federal poverty level, but are still unable to make ends meet. The types of jobs that they hold are cashiers, nursing assistants, office clerks, childcare workers, security guards, home health aides. And while they're vital to keeping our economy running smoothly, they still don't provide an adequate wage to cover the basics of housing, childcare, food, transportation, healthcare, and technology. Which all encompass what we call the ALICE budget, which you can see in your packet on page 2 of the ALICE report that's included. Now, in our community, in the US, 40% of all households in 2018 were considered ALICE. In our community, prior to COVID hitting, 54% of our community was considered ALICE. And we know that 54% that it's below, it includes 37% that is in the ALICE population, and then 17% that is in the federal poverty level. We know that minimum threshold of the minimum income that is needed is not accessible in our community for this 54% of our population. And this budget creates a far more accurate representation of the cost of living in a community than the federal poverty level. Now, we know that that 54% was already struggling before COVID hit, and the 2020 ALICE report was released in May of last year. So we knew that when those numbers were released, it didn't accurately reflect what was actually happening in our community in those days. And so we, among many other United Ways in the country, decided to do another survey, which was not representative as the regular ALICE survey is. It's, wasn't surveyed by the Census Bureau, but we were able to get respondents, over 3,000 respondents from our community, and it showed that of all of those respondents, 64% of them had income below the ALICE threshold, which, again, while it's not representative, it does indicate that the pandemic had amplified the financial hardship that ALICE households were experiencing. And they also suggest that the number of households experiencing financial hardship was growing because of COVID. Our analysis of the actual cost of living in every county in Florida is that 46% of the whole state is within ALICE. And yet for Black households, that number is much higher. It's 63% in Florida. And from 2010 to 2018, which was considered the recovery from the Great Recession, the number of Black households below the ALICE threshold in Florida actually increased 13%, while the number of white households struggling decreased by 2%. So while we know that 2% fewer families were struggling between 2010 and 2018, who are white families, 13% of Black families were doing worse. And United Way Worldwide, prior to the heightened awareness of the racial inequities last summer, had released an equity framework for United Ways nationwide, who wanted to embark on race equity work and really needed a roadmap. It has now been broadened to multiple other resources, and late last year, the entire US network embraced an equity lens that committed us to broadening our understanding of the impacts of inequity in our communities, which is enabling us to address truly pressing needs through our advocacy work. The toolkit in your packet is just the policy section. There are sections which are called levers for each area of our work in United Way. They each include multiple ways to review our work, and like all tools, not everyone is appropriate for every job, but I wanted to share the policy section with you so you can see what we're considering when we're thinking about our policy work moving forward. One of the great tools it provides is a series of questions to ask ourselves in our advocacy work, and I'm sharing them on my screen. How are our policy and advocacy efforts building a stronger base of support for policies that close gaps? How have we increased civic participation within communities of color and other marginalized groups? How are we building or participating in policy and advocacy coalitions that focus on increasing equity? What strategies are we utilizing to build bridges and create consensus among those with dissimilar interests? And are they effective? Three more. Have we noticed a change in local attitudes, knowledge, or values, and how do we know? Which is really a question about who are we talking to, and how would we know that ideas are shifting in any way? To what extent are local organizations improving their capacity to advocate for policy change, and what evidence can we point to? And what specific policies are being developed that will help close disparities, and how are we helping to advance those policies? You can view the entire equity toolkit. It's a publicly available document at equity.unitedway.org. And there's actually a link in it also in your packet. Two more things to go over before we start our presentations. Our advocacy agenda every year is developed through a series of conversations within our own United Way, within our public policy committee, within our partners, but then also with the other United Ways statewide. All of the United Ways statewide support what we call a consensus agenda. And three of the things on the consensus agenda in this last year are listed on the left: improve access to affordable health care, maintain targeted funding of prevention and treatment services, maximize home and community-based services for older adults. Now, typically, though, because they're budget items, those are things that we would be monitoring and watching to make sure that they were funded at levels that we were expecting. This past year, majorly because of the federal funding that Florida received, we were able to see increases in many of those items. And one big thing that we did advocate for directly was increasing the postpartum Medicaid coverage from 60 days postpartum to 365 days. So from 2 months after you give birth to a full year, which is one of the main ways that has been shown to close gaps in maternal and infant mortality rates. We really want to praise the successes that we saw last year in our advocacy agenda, but also with the understanding that it was majorly because of the federal funds, and we need to, try to figure out ways to continue advocating for those levels of funding into the future. And finally, if we were all here in person, you would have received a note-taking page that looks like this. It's page 13 in your packet. If you have the ability to print it, great. If you don't, if you could just take a piece of paper and make 5 boxes. We've asked all of the agencies to consider these things in their presentations. Really, what do we value? What is it that we strive for? Assets, what does our community do really well? Barriers, what are the big challenges that we've seen year after year that we're having a hard time overcoming? And then symptoms, what do they really look like in our community? So not just, talking about, what the constant symptoms are, but also what are our benefits? What are the things that we can lean on when we have challenges? And then finally, what can we do? And if you're able to sort of create this note-taking page for yourself, it will help us in our small group sessions to sort of gather our thoughts really quickly. So our first impact partner presentation is going to come from the ARC South Florida, and I will, Gabe, are you going to share a screen, or are you just going to speak?
I'm just going to speak today.
Okay, great.
I'm privileged to be the first one under the agenda. Good morning, everybody. As I said in the beginning, my name is Gabriel Parra. I'm the Executive Director of the ARC of South Florida. Very happy to be here and share some of our experiences of what we've done within our agency, but more in particular, how we have worked together with United Way as one of the impact partners. The ARC of South Florida was founded about, I could say now 60 plus years. When it was founded, it was because of concerns of parents that there was a lack of adequate programs within the community. And they were trying to get together to be able to find these programs within not only the community, but other areas of the places where they would live. It was very, very difficult for them. Since then, and this group was put together, it is now a national organization. We are part of not only the state of Florida, but also national. There's over 550 chapters around the United States. For the state of Florida, we have 42 chapters. We provide a variety of services, including the services that are funded by United Way, which have been funded for over 15 years now. We feel very privileged to be able to do this type of programs within our community, because we are all here together to change our community for the better. We feel that if we all get in this type of services that we're providing through United Way and other communities, we will be able to provide the services to those that are in need, in particular those individuals that we serve. Again, I'm very privileged to be on the Public Policy Committee as the representative for the executive directors of the partners, and also I'm very privileged to be part of the Older Adults Task Force, which is also led by the United Way. And this is where we learn a lot about what is going on within the adult community and how we can provide services to these that people, again, that are in need. Going back to what we have in regards to our funding, I was going to share a screen. Unfortunately, I had a couple of VIP visitors yesterday and it was impossible, but two programs, again, are funded by our United Way, which is the first one is the one under the early childhood, which is our early education program. This is called Project Thrive. It provides high quality education and therapy services to children with special needs and development delays in the ages of 0 to 5. And we call this our birth program, also serving the siblings of this community, which are the role model and create inclusive environments. These programs run through the whole year. We provide it in neighborhoods that are in special need and economic need. We believe that the family in this particular environment needs to be informed of how to take care of these children that have special needs, and by providing extensive services to them, they can provide better care for their children. The second program that we have, which is under health, is a program that is called the ARC Guardianship Program, which I'm going to go a little bit more in detail because that's where we really serve our adults that are 60 and over. Everybody always asks, why guardianship and why under health? You know, when we first started this program in 1984, which you can see it's been for over 40 years, we found out that, again, it started with children, it started with adults, where there was a lot of situations where they could not make their decisions or their parents couldn't make any decisions for them. The first situation that would happen was the child would be taken away, put in an institution, the same as the adult. And again, because of advocacy, we felt that it was not fair for these families to go through this situation. Also for the individual itself that had a disability was very difficult for them. You know, being in an institution and have all your rights removed was terrible. So since then, the ARC Guardianship program has really done a lot of advocacy, not only local, but statewide and national-wide, to make sure that, you know, people that are under the guardianship program deserve the best services and can still remain with their rights. And that's where we fit in perfectly under the health component of the United Way. And I'm going to tell you why. We have one of our initiatives is statewide and national, is that all people, including people with intellectual disabilities, should have timely access to high quality, comprehensive, accessible, affordable, appropriate health care. Believe me, we are in a situation now with this pandemic that we really found out how difficult it is for individuals, not only individuals that don't have the right to make their own decision, but even the ones that have the rights to make decisions, to be able to access the services that were necessary within this 1.5 years, and we're still going through this pandemic. We found out that communicating and making these health decisions for themselves was very difficult, and we adequately put in place a communication plan within the guardianship program to make sure that all matters of these individuals were taken care of, and there was sufficient information provided to the healthcare providers. It was very difficult in the beginning because everybody really was not aware of what would really happen when there would not be communication between an individual that needed to get the services for health and the individual that was going to be providing the services. So we started implementing within not only our organization, but statewide, different methods of communication to be able to provide that information to the healthcare providers. It was difficult in the beginning, but now I can say we're running at 100%, where every individual that we serve under our guardianship program is meeting the benchmarks that are required for the health of this individual, not only with our funding, but also through the courts. That is very important that they are known through an annual plan that we have to submit to them. The communication and personal decision-making of these individuals also allow them not only to get the health care, but also other services that they need within the community Now, with the changes that are happening within the communities of opening up a little bit more for recreational activities, et cetera, we have been very fortunate that our guardians are now working and starting to increment these outings for these individuals as long as they have been vaccinated and they're well taken care, to be able to integrate themselves again into the community. It was very important. Isolation, as you know, is terrible, and not only for a person that does not have a disability, but those that have a disability is terrible. They were accustomed to receive visitors at their homes. They were accustomed to going out, enjoying life as anybody else would. And once the pandemic hit, it was very difficult for them to be going out and being part of the community, which is one of our mission goals. We again are very interested in continuing providing these services. We have been able to provide this information to the state of our progress within the guardianship program and also through the programs that we have. We have also been able to provide these reports back to our headquarters, or the what we call the mother of all, which is the Arc of Washington, where they put together all this information to be able to advocate for us in the state capitol. We have felt that this advocacy has been very strong in the last months because of all the information that we've been able to provide, including the services that we want to continue implementing and what would happen if these services would not be in place. One of the most critical things that are happening right now, and it's not only under the health program, but also under our children program, and I believe for all your agencies are going through right now, is how are we going to be able to fund our organizations if we don't get the adequate funding from not only the state, but also the federal government. Not only we have advocate locally, but also statewide and also national-wide to be able to make sure that funds that are being released now through different plans, including the American Relief Act, are implemented appropriately and be able to provide the funding appropriately for our agencies. We have been very successful. Right now, there's an agenda that was put together to be presented to the governor of the state of Florida, and also has been sent up to Washington. So several of our state representatives, senators, can take a view of it and do recommendations in regard to this. Once this starts filtering down from federal to state, I think our services will be able to continue, and not only within our organizations, but we also will be able to continue giving those salaries to those individuals that serve our individuals. That is very important. If anybody has any questions right now, I will be more than glad to take them, or we can wait until we are in the roundtables. I hope I wasn't on mute on all this, right?
Gabe, what are some of the successes and challenges that you have seen in the past few years advocating for the ARC here in Florida?
Not for the program that we're funded through the United Way?
No,
Okay.
I mean, what ways have, as the ARC, what successes and challenges have you seen in your own advocacy? You know, I know that you were supporting the guardianship bill, and you might be able to share some of that experience to, highlight, ways that things that worked and things that didn't.
Correct. Well, things that work, it's usually our strong advocates that we have, our self-advocates. We feel that the best voice for us are our parents and the people that we serve, those that can voice themselves as self-advocates. We have, and for the past, and this is not only before during the pandemic, but in the past, we have built a strong self-advocacy program, local and national and statewide, so they can be the voice for us, because as a manager or an executive of an organization, it's very difficult, or not difficult, but when you talk to a representative, it comes challenging because they've been hearing it from all of us. So why not hear it from the person that will be receiving the services or is in risk of losing those services? So that particular training that we're providing right now to the self-advocates is how to speak up, giving them some keynotes so they can talk to those representatives and know that when they talk to them, their words will be heard and they were going to be transmitted to the people that can make the decisions for them. The things that have failed, unfortunately, again, I can tell you right now, this one last year and a half has been not only for our guardianship program, for a lot of our programs, has been the adequate or not the type of services that we provide. We are an agency that provides hands-on. We are an agency that works every day with an individual, providing therapies, providing adult training to them, providing them advocacy of how to protect their rights, etc. When it comes to the point where you lose that communication, it becomes very challenging because it is a part of where we really need to be in contact with them. In the first 6 months of the pandemic was a challenge for us and the learning experience. We now have it under control where we implemented, and I think we all did, virtual communications, other means of communication that we can have that contact. We never suspended our therapy program, our live therapy program, and we did it also virtually. We felt that those families really needed that support from us. I can say that our successes have really overcome our failures. So.
Great, thank you. Does anyone else have any questions for the ARC? All right, we will move on to Care Resource.
Good morning, everyone. My name is Dr. Thomas Smith. I'm the Director of Behavioral Health at Care Resource. And basically, I think I'll share, and I have a few slides if that's okay. Let's see if I can do that. And I'm basically going to tell you a little bit. Hold on. Sorry. Okay. Hold on. I'm messing this up. I apologize. Yeah. Okay, everybody see Safe Syringe program? Yeah. This is just kind of a little bit to tell you about Care Resource and a program that we are actually beginning, and there is one in Miami. And I guess that's a little bit of why today to look for some support from you and on some of the needs that we have or thoughts that what we could use help on or to get ideas about some of the policy change of the advocacy. And if you're familiar, if you're not familiar with Care Resource Community Health Centers, we are in FQHC in Broward and in Miami-Dade counties. We serve the underserved, the uninsured, the underinsured clients to patients for medical, dental services in a diverse South Florida community's needs. So one of the things that we're looking at is expanding our services, which is part of our vision to another population, an underserved population, and that's specifically with the Safe Syringe program, which we are, so this is very much in line with that. Just a little bit of a few of the services that we provide. We provide primary health care, HIV primary care and support, health promotion and testing, case management services, substance use disorder. We have a large medication-assisted treatment program for opioid use, mental health services, as well as a vast array of different dental services, pharmacy as well. When we look at one of the important pieces of the syringe exchange program, which I'll tell you now, there's a ban against using any federal or state dollars to be able to pay for programs like this. So that's where some of that advocacy comes in, that we need support. There is a change, so there is the beginning look at how we can have some federal funding for that. But also another piece of this is that there's Miami-Dade has a strong program, which is great, and we're looking to them for their support and how they've done this. But there is a lot of resistance from police departments, from community leaders as well. So it's looking how to advocate and work through some of those issues. But one of the most important pieces here, if we look at ending the HIV epidemic and addressing the opioid crisis, one of the third pillars here in ending the HIV epidemic is to use different interventions, including PrEP and including syringe service programs, because we know that if we're able to get people clean needles and supplies, then we'll reduce the risk of infection. As we all know, and I'm sure you're aware if you've seen the news and CDC, and every day there's more overdoses that are happening on a continuous basis. And we look at the last, in 2021, or for 2020, the highest number of drug overdoses deaths in history happened. And we also see this, that from one year to the next, because of COVID and the isolation, the lack of treatment, there was more overdoses that were happening in Miami-Dade and Broward counties, and of course, throughout the country. Which that comes to the economic burden of prescription or opioid misuse is $78.5 billion a year. We look at the cost of healthcare, lost productivity, addiction treatment, criminal justice, and primarily what we're looking with one of the big areas with the needle exchange and syringe exchange programs is to help reduce that cost for hospitalizations, for criminal, for all of the medical need. SSPs have been around for nearly 30 years. There's the misbelief that there is a increase in illegal drug use and crime, which is not necessarily, that's not the case. There's a ban on using federal and state funds because of this is an illegal, distributing needles or syringes is illegal. So there's a ban on that we can't use federal funds to do that, so they're prevented. What we know is that needle exchange programs reduce the transmission of hepatitis, HIV, and other infections, which is huge cost to the taxpayer and for those who don't have insurance. People who inject drugs are more likely to enter drug treatment and stop using drugs, which is so important. That's one of the main reasons of why we're doing this. Provides naloxone, which is a drug that helps reverse overdoses. So if we get that out onto the street, that's very helpful. And it protects public and first responders. We wanted, instead of having needles all over the county, and I know in Miami-Dade there was a great success in cleaning those needles off the street, which was something that's super important. And it's extremely cost effective. If we look at syringe exchange programs, the cost, the estimated lifetime cost of treating one person with HIV is $450,000, and hepatitis C, $40,000. So if we look according to CDC, an average cost of a syringe is 97 cents, and we actually get them for less than that. And so it's calculated to be between $4,000 to $12,000 to prevent someone from becoming HIV positive, which is a small cost considering the cost. And without funding for these programs, it makes it difficult to be able to do that unless we're working on private donations and those kind of things. Just as a side note, if you take a look at the picture on the right-hand side, a syringe exchange, the first one is a new needle, brand new needle, how sharp it is. If somebody uses it once, it starts to dull. You use it twice, it really decreases, and then look at somebody using 6 times. Now, for syringe exchange, people that are injecting drugs may inject 6, 10, 8, 10 times a day. And if they're sharing it with somebody else, you can see the risk that goes with that. So it's something super important that we get the clean needles out into the street in a better condition so that doesn't have to happen. What we are beginning is to do a one-on-one exchange and dispose of any of the used equipment. So there are some counties that will allow, like pharmacists, to give out clean needles, but other counties will not allow it. And then also pharmacists, even if they are allowed to be able to give needles out, resist doing so because they don't want to become if they know it's going to be used for harm, they can't give it out, or they don't want to be liable, so they won't do that. So there's resistance. So it's just so important for the programs to exist. What we also do, we'll give free Narcan out to clients and to prevent overdose, anonymous hepatitis and HIV testing, educational materials, and link people to care. So as somebody comes in, we want to get them treated and linked to care. It's super important in that case. And in those cases, there is funding available because they become patients or clients of those services they are enrolling for. But the prevention piece is where it's not funded. And that's where it becomes difficult to get everyone. What we're doing is we're having a mobile unit that goes out into the community to provide syringe exchange, the testing, mobile medical. So if we identify somebody that needs care, we're going to have them be seen right in the van. We'll hook them up with telehealth to be able to provide that care and that medical care. And also we'll go out to provide COVID vaccines and wherever areas we may do that. That's more a scheduled thing so that, we have the appropriate personnel and the vaccines with us. And again, I just mentioned that we have a lot of implementation and a lot of linkage care for those who need care. Another thing is one big area is wound care. So because I identified those needles back there, people that are using needles are injecting into abscesses and they have, endocarditis, and they need hospital care, which unfortunately they don't reach the hospital until they are severely ill, which means hospitalizations, higher costs in that sense. So the prevention piece is so important. I probably don't have to sell this to everybody here. They probably get it, but the importance of it, but that's really where that advocacy comes in. What Care Resources has done is committed to provide some of the funds and put that up, and we're depending on private donations, and United Way of Broward County is sponsoring this too, which is fantastic, and we're much appreciated of that. So I guess as we look through, hold on, I'm going to try to unshare now. Just some of the big points in that sense that, when we look at a syringe exchange program, because of that federal funding that's being restricted or the state funding, we're scrambling to find funds. The other piece of it is what I mentioned before, is that it's finding ways for the community and the commission or the important people in the county to have that buy-in, police departments to have that buy-in, that advocacy, and then also changing the community views to accept and be more open to programs like this. There is hope because there has been some federal funding and it's saying, okay, we can begin to use some of these funds as long as they're sanctioned and they're coming down there, but more likely they're going to be trickled down through states and then into local governments to be able to get that. And that's the Biden-Harris changes in the Relief Act. But so I guess what I'm looking for, or what hopefully in the small groups people can give suggestions on how we can help to inform us and how hopefully we can help to advocate for even stronger healthcare as we lead and feed these clients into programs like all of everybody else is here. Does anyone have any questions or thoughts?
I have a question.
Hi, I have a quick question. I'm sorry, go ahead.
Please, Priscilla, go.
Thank you. It's a terrific program, and I'm just wondering how you find your targets. Who your potential consumers are, or patients or folks. How are you? I know you're taking the van out to the neighborhoods. How much research do you do based on the area where you show up at?
Yeah, we're working with the Department of Health and also with BSO or the police departments in the different areas to look for the hot spots. And then also like the high incident overdose rate areas. However, we know that this is happening anywhere, right, all over. That's the difficulty, and they're moving targets. So as we begin to identify and feel more comfortable with the area or more familiar with the area, we'll go out and we already have like the police departments calling to say, okay, there's a couple areas right now that there's needles all over the place. They're all over in parks. So we're going to go out and clean up those parks, and that may be a location where we're able to be located so that people can get the appropriate tools that they need.
Terrific.
You know, it's still illegal for, you know, it's illegal for these programs to operate, but we have the buy-in, and there is something that will protect us. And the county has given us an RFP the permission to do this. So we do have that buy-in, but at least we have to change community viewpoints on that.
Right. That's what I was wondering, right? Because you pull up in a van, and you know, how are you
Yeah.
communicating to these folks so they're not afraid to step up, and also the educational layer of, you know, how do young people learn that you don't want to, you know, pass on these needles, et cetera.
Yeah, exactly.
It's terrific. It's terrific. It's terrific.
Thank you. Thanks.
And the Idea Center just off Jackson's campus is kind of a proof of concept on a lot of this.
Yeah, they're amazing, and we've been working closely with them. They've shared everything that they could share with us to say, okay, this is, and they've also said, this is what you're going to run into. So how do you advocate, and how do you begin to make inroads with all of those other areas, because this is going to be an issue for you. I promise you, it's going to be an issue for it. And that's the police, you know what I mean, or that's commissions, or the people that don't have the buy-in to say, okay, why are we giving people that use drugs, helping them to use drugs? And it's preventing them from infecting somebody else in many different ways, and being safe to if anything, to decrease the cost for medical care. You know what I mean, that if we can go just one benefit in itself, that's a big strong point.
Well, thank you for that, Dr. Smith. It's the first time that I've seen that photo of the needles, and that was really jarring.
Yeah, it's impressive. Yeah.
Yeah. Okay.
Thank
It's hard to move on from that, but if no one else has any other questions for now, we are going to briefly move on to Betty Leon from the Hearing and Speech Center. Her camera's not quite functioning, so we're going to give her a little bit of grace this morning and just listen to her talk for a moment.
Thank you.
Hi, everybody. Good morning. Do you hear me though?
Yes.
Okay, just confirming. I am having all kinds of computer glitches since yesterday, so bear with me. But well, let me just introduce real quickly what we do, and then I do want to speak to the main issues that have been affecting my clientele, and I'm specifically speaking specifically towards the Medicaid population. Our agency is an 84-year-old organization, and our focus is we are rehabilitation specialists, and our professionals focus on audiology, which is everything hearing and hearing sciences. And then we do speech therapy. There were a speech language pathologist, occupational therapist, physical therapist, behavior therapist doing ABA. And we have a lot of educational professionals as well, because we do a lot of educational programming for the special education divisions in different locations that we work. So our main focus, our main clientele for many years has been the population that has Medicaid and Medicaid dollars. And as you know, in the last many years, Medicaid reform has really drastically changed in Florida, and our community has really been affected by it. I had the timeline and I can't even pull it up. So I'm so sorry I had the timeline, and I will share that afterwards. I will make sure that we share this with the group, the timeline of all the changes that have happened through Medicaid and how that has all come about. But basically, I'll talk about the current situation we're in, which ACA has as we know, they subcontracted the Medicaid contracts to various private insurance companies. For example, Humana, Simply, Aetna, United, just to name a few. Our region is Region 11, and we have about 9 companies that are working here in South Florida with us. However, the problem that we have had is that those insurance companies have subcontracted what is the therapy division to a third-party administrator. That third-party administrator is called American Therapy Association, and we call them ATA. And for many years, I personally, as well as most of the therapy companies all throughout Florida, have been fighting this third-party administration. The current situation is, I even had the CEO come into my office a few years ago, because the issue with this is that they are determining what the professionals get to do in terms of treatment. So my professional may do an evaluation and say that a child needs 3 times therapy for 30 minutes each session. They come back and they give you a level of care and will tell you, well, Betty, we're going to give you a level 4. And a level 4, I don't know the numbers off the top of my head. Like I said, I can't pull up the thing, but I'll give you the top level. The top level, a level 5, is $600. They give you $600 for 2 months. If you were to use regular Medicaid dollars, the equivalent to what a patient would need would pay us, and we consider Medicaid dollars the minimum payable. That would be equivalent to $1,800. So talk about the difference. I mean, my comment to him, I said, do you expect me to pay my clinicians $10 an hour to see a patient? So that is the first issue. That is, it's not financially sustainable for anybody that wants to do it correctly. For me, the bigger issue was I felt it was not efficacious. If I am a professional and I have a degree in this and I have a Department of Health license to treat this patient, why can't I determine what my patient needs? They don't give access to the patients to argue, to have Medicaid is supposed to give you a point where you can argue and defend yourself if you don't get the amount of services you need. They don't allow for that. So what we did a few years ago, Miriam Hartzman and Katie DeBrier from the Florida Health Justice Project, we joined them, and we joined, they actually used 150 of my patients. I was in a Florida Association conference this weekend in Orlando, and she called me out in the audience thanking me for the amount of information we were able to give them in terms of patients. Because what happened was that we started looking at this and identifying to ACA that nobody in this community is able to work with ATA. So hence none of us have contracts, but ATA says that they have network sufficiency. So the argument started with network sufficiency. We're back and forth with ACA with this. ACA's put a moratorium on new plans engaging with them. We are in constant battle. And right now where we stand is that the Florida Justice Health Project has decided to pursue a lawsuit, because ACA is really not taking forward movement on helping us address this and identify the needs of the patients. So the argument right now is, and what we're seeing overall, is that most agencies in this community, and communities, we're with the Florida Speech Language Association, we're working with the Florida OTA Association, and we're working with the Florida PT Association, Physical Therapy Association. And what we've identified is that our patients are really staying at home, not receiving services. They can't find anybody to provide these services. And when they do, which is the issue I had, that if I were to accept this patient, then I wouldn't be able to give the patient what was efficacious treatment for them. And that's why I chose not to work with them, because how can I tell a patient, oh, I'm sorry, I'm only giving you 30 minutes a month? I can't justify that. It's not a professional standard. So we're really going ahead and we're moving forward with this. I can answer any specific questions regarding it, but the other argument that Katie is moving forward with from the Florida Health Justice Project is that it's been monopolized. They say they have, 9, 11 across the state. They have all these agencies they're working with, and really, therapy only answers to one organization right now, which is that American Association that is limiting us. So this is, it was very interesting because I just found out this weekend that they are moving forward with a lawsuit. We were trying to work with ACA and really give them the opportunity to fix it. And instead, they recently announced that they're also Staywell and WellCare were still independent, and we were working with them, and they've officially moved forward by accepting another contract with ATA. ATA will be managing them as of October 1st. So this is crucial and so important for you to know, because our community for many, many years has relied, the children that have autism, Down syndrome, cerebral palsy, speech and language delay, you name it, any child that has any kind of developmental delay and is in school for special needs does need and qualify for Medicaid dollars, and the dollars are there. Now they're just being taken over by this third party administrator. And I am on a big fight. I will fight this all the way because I am here to serve my clients, and I'm seeing that there's just no opportunity right now for us to help them in the current conditions. I'll open it up for any questions.
Thank you so much, Betty. There are a couple of comments in the chat. I don't know if you saw them, but Allison Yeager from Florida Health Justice Project is here on the call. So snaps to them and to you. And, you know, just really talking about the idea of professional standards and what you know your clients need versus what you're able to be, what clinicians are able to be paid for is just sad, really. I don't know if you mentioned a document that you wanted to show. You can actually add it as a file into the chat so people can open it on their own computers.
I'm actually having complete computer problems.
Okay, that's no
problem. We had our
problem.
IT company told us that there was something happened, and I have been having problems with this since yesterday.
All
but
right.
I will share with the group later on as soon as I fix it.
Okay, great.
Betty, I have a question. You mentioned, this is Gabriel with the Arc of South Florida.
Yes.
You mentioned a lawsuit. When was this? When was it put in as a lawsuit with ACA?
Right now, they're working on, they just announced that they will be moving forward with the lawsuit. So Katie DeBreer, which works directly for, I don't know if I'm saying her last name correctly, Miriam Hartzman or Miriam, she used to work with the Florida Justice down here.
Miriam
Harmatz, thank you. And basically, she was there and she was giving us a summary of all these last minute things that have happened now in July and June. So in June and July. So she told us that she was announcing it at this Medicaid meeting I went to at this conference, that they will be moving forward with a lawsuit. And the 2 points, the main point is network insufficiency, because they claim they have providers. And if you look up my agency and all the therapists historically that have worked here and still work here, we are on all the panels of the insurance. They will not remove us, even though I have asked them to remove us. So they're providing false information. They really are providing false information to ACA and to the community. And the bigger picture is that these patients, now we have a bunch of patients that have found, there are a few providers, but the providers that are accepting, in my opinion, have chosen not to follow what is standard practices. So the provider says, and I've talked to these providers, they're colleagues of mine, some of them, well, colleagues in parentheses, and I say, you know, how are you meeting their needs? How are you seeing these patients with this kind of, and they're like, well, if they give me $5, I do $5 worth of treatment. Mm-hmm. And I find that unacceptable. If you're going to see this patient, it is your responsibility to provide what that patient needs in order to be treated professionally and well and make progress. So we're in such conflict right now, but what I will do is I will give you that timeline and the document that I have that came directly from Katie. And I will also share, I'm going to ask her to give me some future dates of that, Gabe, so I can answer your question when she plans on moving forward with this and what we can do as a community. But I was so happy to see last year, all the organizations, the state organizations, including our boards, have gotten involved in giving opinions. And so we hope that this will move forward, but they are powerful. They are very powerful and they have a lot of money. And that CEO literally threatened me personally and told me, if you do not join me, I will take you down and I will close you. That's what he told me, basically saying that you will see your patients under my conditions. And it's so sad. We're in a really hard situation because I'm helping these families as much as I can, but Medicaid dollars are there and they are needed for the sake of the patient, not to be used in these third-party companies.
Oh, thank you, Betty. I know we've talked about this in the past, but I'm really glad that you're able to share it today with this group of people who can hear it directly from you.
I'm interested in knowing, many of you do have programs that serve children with special needs and disabilities. Do have any of you, or can any of you comment how it's affected your schools or your practices or your centers?
Well, I think you are very aware of our situation, Betty. What we have, the biggest challenge is the billing component and the delay on the payments to the agency in regards to the therapies that we're providing.
Right.
And Betty, while folks are thinking about that question, I wonder if you might say just a little bit more about appeal rights. You mentioned there's supposed to be a point for clients to appeal. What's the barrier to that, or what's the limit?
That's Linda, that's a great conversation, and that comes up almost in every meeting I have, because Medicaid, I tell you that it is a challenge for even me to get through to them. So I have intentionally sat with, I'm very interactive with our patients here, physically here at the office. And I've sat with families to help them go through the appeal, and we get on the phone, and between press the prompt for this, press the prompt for that, it is so difficult, and especially if the families don't speak the language, so difficult for them to get that appeal in. But Medicaid we've complained to them so much. This whole process has been a few years, so they have made it better so that there's a website and you can plug in your concern. But the problem we have, and historically we know that these families do not have the tools or access or even the initiative to fight for themselves. So we have to fight for them. And guess what? They don't want to hear from me anymore. They don't allow me to put in that claim on behalf of the parent. It has to be the family. And they always tell me, I have to speak to the family. I have to speak to the family. And then sometimes I'm sitting here with the family, and the lady who's telling me, let me speak to the family. I'm like, well, I'm going to translate for her. She doesn't speak English. And then they don't want to pursue it. So that is one issue, access to the appeal. But these third-party insurances are it's gotten so complicated that we can't even figure out. This third party says that if you have an issue, you have to appeal through your insurance. So you go through Humana. When you call Humana, Humana has no idea about anything because Humana doesn't manage the therapy portion of it. So they send us back to ATA. ATA, when ATA gives a level of care, they were very, Katie explains this wonderfully. They are very slick about, I'm going to use the word slick about how they manage it, because they will not deny the service. So when my therapist puts on a plan of care, I want 3 times 60, 3 sessions for 60 minutes each a week. They will say, here's your level 5. We're approving a level 5. And they limit it by, by dollars, by putting, Katie calls that hard limits. That's the other argument that she's making. She's making it that by putting a level, you are automatically introducing hard limits to what is Medicaid, and Medicaid is not supposed to have hard limits. So she believes that we have a very good argument towards this, because that's the problem is they are not able to appeal because there was never a denial. And the family doesn't understand that they are having these hard limits. They are just being told by the companies who are accepting it, Mom, we're going to allow your child to come 1 time a month. I am hearing stories of patients that they're going to clinics, and I'm like, how is that working for you? How are you receiving your therapy? First of all, these parents are describing ABA therapy. So what happens is they go to a therapy clinic for speech therapy, and since they know they can't really give speech therapy, they say, don't worry, Mom, we're going to give you 30 hours of ABA. And the mom is complacent with that because she really doesn't fully understand that they're different. These are monsters being created as we speak. And then the other thing is that the mom will tell us, well, they told me that my child only needs 30 minutes a month. And again, they're complacent with that because these parents, as we know, our population is very grateful and thankful for anything that they are given. And they will not argue, they will not demand more. It's a systematic creation that has happened. And that's why we're trying to fight it at a bigger level, because these families really don't have a way to appeal. There's nothing to appeal because they've not been denied, but yet they're being limited and they don't even know it, and they're not being told that. So sorry, it's complex, and if you're not following, it's become very complex.
So it's both, it's a both and, right? It's an educational issue for the families to understand what their rights are and how to advocate for their own kids within this crazy system that most of us can't navigate either. But also on the payment side, just logistically, Gabe mentioned delays in payments and not having enough for the families. So
You know what I did?
when you offer them
Right.
30 minutes a month, then you think like, well, the therapist told me I only need 30 minutes a month, so that's what I'm going to get.
Right. And I brought this to the board, to my board of speech and language pathology and audiology. I said to them, they're changing our standards of professional practice, because if a child is severe and we test and they're scoring and everything shows that the child is significantly severe, it is not adequate to recommend 30 minutes a week. And these clinicians in the clinics that are accepting this which by the way, a lot of these are on the Medicaid Fraud Watch Committee. They're not practicing well. A lot of these agencies are training their therapist or telling their therapist, hey, this child has ATA, therefore you only need to recommend 30 minutes a week. So they're being told what to recommend, changing. I mean, it's just such a crazy dynamic. It's unbelievable.
I'm hoping that you are able to stay on for the remainder of the session so that
yes,
I wanted
to say one more quick thing, which those of you who are on this conference, I am with Katie and with many other organizations. We're taking list of these patients. We're creating a very formal document for her, for every patient that reports that they don't have access, that they can't find a provider, that they're being seen for less treatment than what they're supposed to be seen. These are the clients we want to have documented. And I was the one who created the Excel form that they're now using across the state. So if you guys send me an email directly, I am getting all this information. My staff is organizing this for the lawsuit that's coming. So just sharing that.
Thank you so much, Betty. I'm sure there will be more questions later on in the small group and large group discussions.
Wonderful.
The Healthy Start Coalition of Miami-Dade, Amy Olin, are you able to unmute?
Yes.
Hi there.
Good morning. Hello. If possible, I would like to share my screen.
Yeah, go ahead.
Okay. Okay.
And I'm gonna do one piece of housekeeping while you're doing that. So we are running a little over on the presentations. If we're going to get through 4 more presentations and have small group discussion, we need to keep them closer to 8 and not as close to 15.
Absolutely. Are you able to see my screen?
Yes, we are.
Super. Okay. So my name is Amy Olin. I'm a senior consultant with the Healthy Start Coalition of Miami-Dade. And I'm just going to go over a bit about the coalition and our programs. So the coalition is a nonprofit 501c3 community-based organization. We're designated by the state of Florida to serve as Miami-Dade County's prenatal and infant care coalition. We were incorporated in 2001, so this year we're excited to be celebrating our 20th anniversary. We provide service to all of Miami-Dade County. Our mission is to reduce poor birth outcomes, premature births, low birth weight, infant mortality, as well as to improve the health and developmental milestones by providing education and linkage to resources in our community. We work with local healthcare providers to ensure universal risk screening for all pregnant women and infants. And we partner with a network of local community-based organizations to plan, coordinate, and provide high-quality health and educational services. Our target population is pregnant women, children birth to 3, women of childbearing age, fathers, and families. All of our services are free. A bit about our programs. Our Connect program is a coordinated intake and referral service. It's meant to be a doorway to a system of care for pregnant women, infants, and interconception women, that's women between pregnancies, and new moms. The goals of the Connect program is for families to receive the best services based on their needs and preferences. We have a standardized client intake and engagement process to assess and determine eligibility for multiple programs. It serves as a triage system for the whole county. And this helps us avoid duplication of services And we use the Healthy Start Universal Prenatal and Infant Risk Screens as our primary source of receiving clients. So the Healthy Start Prenatal and Infant Risk Screens are in Florida statute, and all prenatal care providers and birthing facilities are required to provide the risk screen either at the first prenatal visit or after an infant is born before going home. The screens are available in English, Spanish, and Creole. And then folks who either have needs that are identified after one of those screens are completed, or if they didn't receive the screen, or if a community program has someone that they think would be eligible for our services, they may use a self-referral form as well. So the home visitation programs that our Connect program assesses for and links families to include the Jasmine Project, which is a federally funded Healthy Start program, Healthy Families Florida, the Healthy Start program, which is the Florida State Healthy Start, and the Nurse Family Partnership. The Healthy Start program is one that is coordinated by the Coalition for Miami-Dade County. And it is a home visitation program that provides pregnant women, new moms, and families with coordination, support, and the education needed to help achieve a healthy pregnancy and healthy baby. We have a pathway of services, including initial assessment, various screenings, and educational pathways, prenatal education, parenting, breastfeeding, stress reduction. One of the important screens that I want to highlight today is the Edinburgh Postnatal Depression Scale. This screens for perinatal depression. We know that 10 to 20% of women suffer from depression or anxiety during pregnancy or in the postpartum period. The Edinburgh Postnatal Depression Scale, when we identify moms who seem to have symptoms of depression, we will refer them to our program that is called You're Not Alone, Moving Beyond Depression. And that program is partially funded by the United Way in Miami. It's an evidence-based comprehensive approach to identifying and treating depression in mothers who are also participating in a home visiting program. And it's been shown to be extremely effective for pregnant and postpartum women. We know that perinatal depression is the most common complication of pregnancy and childbirth. Women who have untreated depression during pregnancy and postpartum have trouble sleeping, poor nutrition, inadequate weight gain. They're more likely to use substances and less likely to follow the advice of a healthcare provider. The infants who are born to moms who had depression during pregnancy are more likely to be born premature, have low birth weight, have developmental and cognitive delays, more crying and colic, problems with attachment. So in Miami-Dade, so we implemented the Moving Beyond Depression program in October 2016. And so from implementation until the start of this past fiscal year, we have served 592 women with our MBD initial evaluation, 417 women enrolled in the program, and 378 women completed treatment. 80% of those moms experienced depression remission, which is really a very good number based on national averages. We are still, since we just finished our fiscal year, we're still kind of tallying the numbers from this past fiscal year. And so all of these numbers are significantly higher with our services. We're just not quite ready to present on them yet. Through our Healthy Start and Connect programs, just stepping back and looking at the numbers, our Connect program had 39,937 referrals last fiscal year. And we were able to provide services to 18,500 mothers and families. About half of those were prenatal and half were postnatal or infants. 76% were Medicaid. Our Healthy Start program provided, had 4,400 plus referrals, and we provided services to 2,900 patients. All right, and so talking a little bit about some of the values, assets, barriers, symptoms, and solutions. So some of the values that we've been able to identify, we know that infant mortality and infant well-being are often used as a barometer for the overall health of a community. And as previously discussed with like our Moving Beyond Depression program, untreated depression in women who are mothers is incredibly important. It has potentially lifelong impact on the infant and the family if that depression isn't treated and mom isn't kind of empowered to get help. And so it's, you know, taking care of our infants and the parents of our infants is incredibly important. Some of the things that we do well, so the universal prenatal and infant risk screening, it's universal in that it is, you know, required by statute throughout the state. It's a standardized risk assessment. And the fact that we are able to have all or most pregnant women assessed for various risk factors and referred for free services is incredibly wonderful, and we're very grateful that we have that system in place. But some of the challenges that we have seen that are impacting us, even though our services are free regardless of marital, immigration status, etc., we do find that a lot of folks who would be eligible for services are fearful about receiving them. They're fearful of signing up for Medicaid. They're fearful of receiving Healthy Start or Connect services because of like the public charge and their concern about how that may impact a future citizenship application, or just they're afraid about just the immigration and enforcement. So we do find that we're having fewer of those folks come forward and accept services. And that is kind of stepping back even further, a bigger problem if mom is not able to pay for her medical care and she is fearful about applying for Medicaid. That's an indicator that she's also not receiving the proper prenatal care, which we know is incredibly important for, you know, health outcomes. One of the other challenges that we've seen, just the pandemic has heightened issues. We've seen more unemployment, you know, more financial instability, more depression, more anxiety. So, and the disparity, the gap has definitely increased. We, like most other providers, have, you know, changed over to telehealth and for many of our services, and that has been both a blessing and a curse. It, you know, has really kind of allowed us to provide more services. We're cutting out, you know, commute times for home visits. And it is a way that a lot of parents appreciate connecting with us. They're used to the technology. They like using that kind of technology. Although some families, it doesn't work well for them and they don't have the resources to access all of the technology. So it can be a challenge for some. And we're also finding a lot of families are getting that Zoom fatigue that so many of us are getting. So also another challenge, we have very limited local resources for prenatal or perinatal depression treatment. So for those folks who can't afford to pay for their treatment either through private insurance or private funding, there are very long wait lists for mental health care, and there are very, very few providers who specialize in perinatal depression and perinatal mental health disorders. And so we often have a wait list for our Moving Beyond Depression program because I mean, it's always full. And that runs into one of the other challenges that many of you have also mentioned. Funding is definitely a challenge for us. We've applied, we continue to seek and apply for additional funding sources for these services, but it's limited. So that is a challenge. And then some solutions. We were thrilled to have the announcement of the Medicaid expansion to provide postpartum services through 12 months, as was mentioned earlier. That was excellent news. And then expansion of mental health funding is also excellent, although, and we're still exploring how we might be able to integrate that into our services. As Betty was explaining the challenges with ACA, ACA is one of our funders as well, and they definitely have limitations on what services they will fund through our programs, and so that is certainly another challenge. So, and that concludes my presentation. Are there any questions?
Amy, I have a question. You mentioned that there were too few providers that specialize in perinatal depression. Are there so few that you could just name them and tell us who they are? Or is that a list you might be able to share with us afterwards? I'm curious which ones do and which ones don't.
So actually, the Moving Beyond Depression program, which is a national program, the Healthy Start Coalition of Miami-Dade has the only certified providers in the county and actually in South Florida. There are a few other providers that are private providers who do specialize in perinatal depression and mental health disorders. However, they don't provide sliding scale or reduced cost or free services. And so it ends up being the biggest challenge for those folks who just can't afford treatment. But I can share more information via email later that we can share with the group as well.
Yeah. Thank you so much, Amy. Yeah, I think that sort of echoing Betty's concerns about pay for services that are necessary in order to actually treat a concern is a huge issue that we're going to continue to have unless it's addressed. Providers not accepting Medicaid is a really hard challenge because they are trying to, they are, most of them are self-employed, right? Like most therapists have their own own company that they pay themselves through their provision of services. We do have a hand up. You can go ahead and unmute yourself and just go ahead and ask your question.
Good morning. This is Makita with State Rep Dottie Joseph's office. Just for clarity, if each person can kind of give, I guess, a quick reminder of like what can local or state offices do. I think I heard earlier, very early on that, I'm sorry, I'm on like two screens, very early on that there were some programs or some things that we could not do, or the state or local offices are not going to be able to help with outside of, I guess, the federal opportunities. But if you can kind of like restate what the opportunities are for us to help, that would be really grateful for myself, because I'm multitasking and taking notes.
Yeah, and Makeda, we'll have a concise summary of each of these sessions that we'll be writing up and sharing out as a public policy committee and as our organization. But I don't know if you're able to stay through the breakout sessions, we'll certainly be providing some of that information at that time.
I will try to. Thank you.
Great. And we're recording, so if you want to go back and watch after, you can do that too. Okay, does anybody else have a question for Amy? All right, we are gonna move on. Is someone from JCS here? I'm not sure. I see her. From Jewish Community Services.
Hi, everyone. Good morning.
Sorry, Morgan. I was like, I know I saw you earlier, but I couldn't find you at this time. Okay, thank you so much for being here this morning.
Of course, of course.
I'm gonna say it again. So we only have 30 more minutes for this session. So I'm not sure we're supposed to have 20 minutes of breakout after these presentations. So we still have JCS, Open Door Health Center, and United Home Care. So I don't know if there's any way to keep it to just a few minutes, that would be great.
Sure, short and sweet, just how we like it.
Yeah.
So hi, everyone. Good morning. My name is Morgan Weinblatt. I'm actually the Director of Resource Development and Engagement. And my team actually just looped us in here because we've been sort of boots on the ground with the Surfside tragedy. So I actually came on board a year ago, and I feel like it's just been one crisis after crisis from the pandemic to Surfside. So I guess in terms of some of the challenges we're just seeing right now kind of echoes a little bit about what everyone's been talking about. Really, our bread and butter is in the mental health space, and we're just seeing a lot more whether it's uninsured, underinsured, or individuals that can't afford services, they continue to come to JCS, and we're really open to everyone. We really do not decline any client in need. And we're just seeing more and more of that need in the community, particularly with regard to the pandemic and now with Surfside as a sort of result of that. And we do anticipate this to be like a 3 to 5 year process. So our team is sort of in this moment of how do we continue to keep our doors open to everyone and provide services to everyone in need and attract, licensed and really great clinicians and just continue to serve the community where the stigma of mental health has sort of decreased, I would say, over the last few years. So we're seeing, I guess, more and more people come to us for those services. And, along with everyone on this call, it seems like we're all trying to do our best in terms of diversifying fund sources and just trying to stay relevant. But it's getting harder and harder. So that's really where we're at right now. I don't know if anyone has any questions, specific questions, but I guess that's just a very brief overview.
Morgan, do you have any, like a report from GCS with, talking about the increase of calls or anything like that we could share out over the afterwards?
Absolutely. So we do have data from our 211 helpline and our contact center. So I can absolutely share that data with you.
Great.
Because that really informs our decisions in terms of what are people needing in the community. So I can share that with this group.
Yeah, that would be really helpful, Morgan. Thank you so much. Does anyone have any questions for Morgan? All right, Open Door Health Center. Are you here?
Dr. Soto's here.
I don't.
She's on mute.
Yeah. Okay, so I'm gonna move forward to United Home Care, and we'll come back to Open Door Health Center if they're able to share at the end. So UHC, are you ready?
Good morning, everyone.
Good morning.
My name is Ana Leon, HR Director at United Home Care, and I'm here with Blanca Ceballos.
Hi, Community Liaison here at United Home Care.
We are a non-for-profit organization founded in 1963 as a pilot program by United Way. We became an independent home health agency, and we've been in servicing the community for almost half a century. The focus that we're going to have today is the impact of minimum wage in home health. We're going to share the screen with you guys. First one, go to the first one. This one, first one, over there. This one. Let's go to the first one. Bear with us for a second. Go to the first one. Okay, the impact of minimum wage in the home health and caregiving industry. As we know, the Florida Amendment 2 on November 2020 raises the minimum wage from $8.56 to $10 an hour. And that will be increasing every year by $1, up to $15 on 2026. And then forward, it will be according to the adjusted for inflation. Okay. Increasing the minimum wage too quickly, it's going to put a great pressure on home health agency, causing some to go out of business, which we have already seen, or laying off workers. This is now serious for all of us because the increase will affect the home health and caregiving industry. The next one. Home health agencies need to make enough, not only to pay the workers, but also to educate them, get background checks, drug tests, pay for licensures and accreditations. If the nonprofit organization that participates in federal and state funded programs with limited and fixed reimbursement rates and funding allocations, we're not going to be, we don't get the increase, we're not going to be able to offer these services. The current reimbursement for HHAs is between $15 and $17.46 per hour. The Home Health Association is asking providers to come together and pressure legislators, Agency of Healthcare Administration, Department of Elder Affairs, and the government office to increase Medicaid and Medicare reimbursements. Home health agencies, assisted living facilities, and nursing homes are extremely concerned about being able to keep their doors open and keep their employees on their payroll. We're all facing these difficulties right now, and Florida's aging population continues to grow. It's not going to stop. On 2019, it's been our 65 and older population made 20% of the population in Florida, and is expected to grow on 2030 up to 30%. Healthcare workers' demand is expected to continue growing. Retail, hospitality, and other private businesses, they've been able to increase their wages and incentive attract job seekers by bonuses. They can do this because They can increase their prices on their services. They can lower their profit margin, but we can't. We are very limited since we participate in funded programs, fixed reimbursement with fixed reimbursement rates. This is an example so you guys can see United Care currently serves 22,000 hours per week. In a year, it's 1,144,000 hours. $1 each year for those hours will come up to $1,144,000 cost per year. It will be a cumulative impact of almost 6,000. It's going to be 5,720,000 in 5 years. This is not sustainable unless we get a reimbursement increase. It is imperative that we obtain increased reimbursement rates for these programs, including Medicaid and Medicare, to continue providing services to the older adults and our community. The other challenge that we're facing is the workforce shortage with the pandemic aftermath. Pandemic caused a huge disruption in the labor market and exacerbated the existing shortage of workers in the healthcare field. Parents were staying home with their kids, companies were shutting out, daycares were closed, schools were locked down, and the fear for COVID or taking care of their affected parents or kids were some of the reasons causing this problem. This year we have seen one of the most generous unemployment benefits checks since the recession of 2007 to 2009. COVID-19 put 20 million Americans out of work. The enhanced unemployment benefit has delayed workers re-entering the economy. Companies are struggling to fill positions and unable to meet clients' needs, putting every organization at risk of losing businesses during these trying times. The existing system has unintended negative impacts. Florida unemployment rate in May was 4.9%. The goal for unemployment insurance should be a bridge to return to the workforce. And this is we try to do it very fast because I know we're short of time too. So this is our presentation for today.
So in summary, what we need is to make sure that the reimbursement rate is keeping up with the cost of providing services, and that we're not left behind, because we will not be able to sustain the increases in salaries to support the programs. So this is meaningful in the Medicaid, Medicare reimbursement as well, and we see that we might be getting some relief through the amendments. But typically we serve those clients under the Medicaid managed care long-term care plans. We participate in all of the plans as a home care provider. So should the funding come to those plans, the important piece is that home care providers that serve clients through those plans are not left out of the equation, that they can see the trickle down in the contract payments to home care agencies like ours. And then on the state funded programs like Community Care for the Elderly, the Alzheimer's Disease Initiative, there typically the contracts are very fixed and budgeted. And we would also need for state legislators to be a part of making sure that there's an increase to those contracts so that they can trickle down to salaries.
Thank you so much for sharing that. It seems like there are so many common concerns among all of us. The questions that we, sort of wanted you to think about, did anyone get to, whether or not any of these could actually, the solutions identified could actually be successful in our community? So I guess the first question is, somebody just, volunteer yourself. What are the themes of the concerns expressed? I wasn't in your rooms, so please share.
Well, I can start by saying that, it's interesting to see that there's a level of frustration, right? So people are facing so many of the same challenges and the solutions can be difficult to arrive at, or it's layered, so it's not just like a quick solution. I think what I felt from our group was it's great to be part of what's happening today, where people can exchange ideas and share their frustrations and their challenges and see how other folks are dealing with it and learn from them. So it definitely has felt like this has been a very productive day in terms of people connecting and learning from each other. So yeah, we know there's a need for funding, and that the needs of our community are greater than some of the solutions that are available at this time.
Mm-hmm.
And we need our local folks to buy in so that we can move the needle. So that's just what our group had to say.
All right, anybody else?
Happy to bring some takeaways from group one.
Yeah, thank you.
Yeah, no problem. So two things that came up were informing the state legislature on the work that our organizations are doing on the ground, so that they have the understanding of how the programs work and how the policies that they will pass and the allocations that they do will impact the work that they're doing. And so Gabe gave the example of state hospital workers getting a pay increase, and that impacting, the expectations, and I think the workforce of the providers, saying that, state health workers deserve a raise, but a lot of people are doing, their kind of work that they're doing, for example, in the ARC, and he can talk better about this, includes like providing nutrition, vacation, recreation opportunities. And so this idea of compensating our workers for the work that they're doing. And so some solutions that were proposed are, as advocates, not just organizations, but the clients themselves having really an impact when they reach out to our legislatures personally and, make a call for action. So that would be something that came up during our conversation.
So providing a space to let people speak for themselves to their elected officials.
Yes.
Great. All right. Did anybody else want to share? Did group one?
I can't remember what group we were, but I would just say that a CEO from New Horizons, Michelle Sweeting, I think did a good job in our group of taking the workforce issue that's come up from several folks, and this idea that there are not raises built into the state contracts like there are in other industries. She did a good job of relating that back to this, really the effect being an undermining of the safety net. And that's something we don't talk about. We're talking about we need money for raises, for workforce, but let's think about when we're talking to legislators, what does that really mean? So I thought that was great. And then the second thing, Betty from Hearing and Speech, we talked a little bit more about what's happening there. And Betty earlier shared with all of us that the level and length of services provided, the efficacy of those services is not up to par where it should be. But I thought in our breakout session, we took it a step further, and Betty talked about this massive group of children with disabilities that is being created with the combination of COVID and isolation from school, combined with the fact that kids are just not getting the therapies that are needed according to professional practice. So that combination, how dangerous it is. And when you think about a whole population of children, you think about us creating children with more disabilities than they may need. I mean, that's truly a sad thing.
Yeah, the idea that because the issues are not being managed, they're being exacerbated over time, that like children are not being, through therapy, being taught the skills that they would need to, develop further at the right times in their development. It's really tough.
And the problems that will create down the road. When we don't, we all know when you don't address the issues early services is an opportunity to address issues early and create the best possible outcomes. By kicking that down the road by a year or 2 or 3 or 5 or 10, we all know that that doesn't make any sense. Yeah.
All right. Okay, is there one last group?
Beth, can I make one more plug while we're waiting for that last group?
Please.
All right, we didn't really talk about it in our group, but I just wanted to remind folks that at the federal level, you know, there's all kinds of relief packages being considered with regard to what United Home Care shared, their workforce issues regarding aging and older adults. I mean, we are hoping that older adults are not negotiated out of some of what's being proposed at the federal level, because there is a huge opportunity right now on the table for those federal legislative efforts to result in more pay for our workforce here in Florida that is providing home and community-based services for older adults and people with disabilities. That iron is hot right now. I think our biggest concern should be, are we as a community chasing that opportunity and advocating for it as much as we could? Or are we going to sort of let that opportunity pass us by? I think that's a big question for us and a timely question.
Yeah, like interesting, like that the report that I think we some of us saw last week that the governor, the state actually shared a plan for spending, you know, money on this, and they have not talked about it because it is an expansion, extension, whatever you want to call it, of Medicaid, but they haven't talked about it publicly, even though it's a huge benefit to the community. I think group 4, I don't know, Allison, I don't know who was the lead in your group, but the public policy committee member who was in that group stepped away. I don't know if someone from group 4 could share out one or two.
Yeah, I can say something. Sure. We also talked about some of the workforce issues and the connection between the challenges that the workers themselves are facing and the way that then connects to access challenges and drives the access challenges. That I would say that was the focus of the conversation. But I think this bigger issue of the systems really being oftentimes so cumbersome and almost designed to impede access was, I think, another thing that people were starting to get to. And we heard that from a lot of speakers.
Okay. Thank you so much, everyone. I know the end was shorter than we had hoped. We'll try to figure out a way for the next 4 sessions to move more at a more rapid clip. Lastly, really, what's next with all of these is, the Public Policy Committee will be meeting and sharing and discussing among ourselves, like what each of us heard during these 5 sessions. We'll be sharing out some roundtable reports summarizing the sessions with all of the recommendations. I will be very quickly on August 5th moving into discussions with the statewide policy team to inform the statewide consensus agenda. And then any issues that don't bubble their way up to the top to the statewide agenda, we can still consider as local issues that we want to tackle, just as United Way of Miami-Dade with other partners in our community. And then, hopefully being able to invite you all to future events and discussions with elected officials around the specifics that we are trying to identify here. And then really providing some advocacy support and capacity building for agencies. And, to your point, trying to provide opportunities for clients to speak for themselves, not just all of us speaking for them all the time. Again, thank you for bearing with us through shifting to Zoom. I realize this would have been much more amazing in person, but I really appreciate all of your time and participation. And if anyone has any final thoughts or questions, go ahead, but we're at noon, and I want to give everyone huge.
Beth, I just want to jump in and thank
Yeah,
you
go ahead,
for
Mary.
pulling this together. You know, I thought it was very informative, and again, thank you everyone for participating. But Beth, thank you very much for your leadership in this. This was great. Thanks.
Thanks, Mary.
I just had a comment. One of the things that kept coming to my mind is the access that people don't, you know, the services that won't be provided because of a lot of these issues. And it really is just, what's our short-term solutions? You know what I mean? Because a lot of these things are going to be long-term solutions. I begin to look at and say, what is everybody doing in the community to like take care of the people that need the care? You know, if Medicaid's not reimbursing and you're not able to do it, which is not really a question for the group, it's just a question to put out there, you know, in that sense, how do we resolve those things immediately? You know?
Question, huh? All right. Well, I think that those are the kinds of questions that we're going to try to answer, right? You know, what are we able to do? What are we able to advocate for? So thank you so much, everyone. Have a great day. We'll be sharing out all sorts of resources after. Thanks so much.